Good morning, everybody. This is the Early Therapeutics and Rare Cancers Committee meeting, and thank you for being here. And we're going to start with Dr. Monica Mita, who is the co-director for the Experimental Therapeutics Program at Cedars-Sinai in Los Angeles, and she's going to speak about new drugs in oncology. She always gives a wonderful talk, and hopefully this will prompt some new ideations. Dr. Mita, go ahead.
Great, thank you, Dr. Cruz-Regan. Thank you for the invitation. Thank you, everyone, for being here. It's relatively early on the West Coast. I will talk again about some drugs that I'm actually working with in clinical studies. And I will start, as always, with a reminder of what we discussed over the last several years. So in 2014, we started this little lecture series, and we discussed the CDK inhibitors, cancer stem cell, targeting cancer stem cell, bromodomain inhibitors, immune therapies, immune conjugate, and then nanoparticles. Some of them have been approved, others are still in clinical trials. In 2015, we discussed new anti-angiogenic treatments, another small session on cancer stem cell targeting, pro-apoptotic therapies, some of them are approved, inhibitors of the PI3K/mTOR AKT pathway. We also talked about FGFR inhibitors and novel proteasome inhibitors. In 2016, we discussed MAP kinase pathway inhibitors, WEE inhibitors, hedgehog inhibitors, and then there was a full session dedicated to immune therapies, which at that point were somehow at the beginning. As you all know, since then, this area has pretty much exploded. 2017, we talked about immunomodulators, anti-metabolic drugs, a dual inhibitor, BRAF and PI3K, and some old drugs, antitubules and vascular disrupting agents that are kind of having a new life. 2018 was a pretty busy year. We had topics on HSP inhibitors, dual HDAC and antimetabolites, new immune therapies like ICOS agonist and CD122 biased agonist, also RET and NTRK, and as you know, both were approved. So important to select the target in some tumor types. 2019, we discussed bispecific checkpoint inhibitors, antibody therapies or immune conjugate, novel mechanism of action, small molecules with the sodium potassium ATPase inhibitor, other new therapies like KRAS inhibitors, ADC targeting LRRC15, an ATR inhibitor, also different other new immune therapies in combination with STING inhibitor, LAG3, and also an update on use on immune therapies on HIV positive patients. In 2020, we discussed a new target, agonist of GPER, a way to target HER2 with the toxin immune conjugate, and the new approach to antigen presentation with a squeeze methodology. So what I want to discuss today briefly is a new immune modulator by downregulation of MDSCs, and that's a drug from Amphibian. And this drug is a bispecific bivalent CD33 and CD3 T cell engager and addresses immune suppression by directly depleting myeloid-derived suppressor cells and promoting T cell activation. So we'll get into more details on that. And then I'd like also to touch base on a new drug that we have in the clinic that inhibits selectively Axel, MER, and CSF1. So I'll start with the Amphibian drug, and as a really brief background, we all know myeloid-derived suppressor cells suppress anti-cancer therapy. They're dynamically recruited from the bone marrow to tumors and lymph nodes in response to cytokines produced by the tumors and activated T cells. So patients with cancer usually have increased myelopoiesis and increased MDSC that will contribute to immune suppression. So the MDSC inhibits dendritic cell activation, antigen presentation, effector T cells in the tumor microenvironment, T cell proliferation, activation, and differentiation, and also can promote dendritic cells becoming more tolerogenic, also inhibit, promote Tregs, and overall create an immune suppressed milieu. So a lot of research has done on the MDSCs, and looking back at different cohorts that were treated with immune therapy, it was clear that increased MDSCs correlate negatively with clinical outcome. And as you can see here, there was actually a meta-analysis, pretty large, looking at the association of MDSCs and overall survival, and clearly demonstrated that there's a negative correlation across multiple solid tumors. Also, in patients treated with nivolumab, mainly melanoma patients, higher baseline peripheral MDSCs correlate with worse survival and non-responders, as we see here, the overall survival in months between patients who high MDSCs and low MDSCs, and also difference in responder, non-responders by looking at the MDSCs peripherally, which is a relatively easy way to do. So this is something that could be used in future studies to eventually screen patients. So this platform, which is called Restore, is designed to selectively and potently deplete MDSCs and activate T cells. And what it's doing basically is inhibiting the CD3 and also CD33, basically linking them as T cell cytotoxicity like that. And the potency is really high in sub-picomolar range. So it induces T cell mediating killing of MDSCs and drives T cell activation. In preclinical studies, this molecule has been shown to have really high avidity, binds bivalently to the targets and induces target cells killing, is also very selective and pretty safe in what we've seen in preclinical models. So basically, this drug is given subcutaneously, which makes it relatively convenient for the patients. They can do it at home. And that was considered to be an advantage because it's a lymphatic absorption and relieves MDSC suppression directly in the lymph node, which is a critical site for the immune activation, but also has a systemic exposure. So there's this T cell mediated killing of MDSC in the tumor microenvironment and further in the circulatory system. So just to briefly, they have really clear experiments showing that this drug binds the CD33 and not binding to neutrophils and monocytes, just the MDSCs. The clinical study started with the all solid tumors, phase 1 with the dose escalation, and then a combination with pembrolizumab, with defining MTD and recommended phase 2 dose, evaluating safety, assessing PKs, with an idea to go in some expansion cohorts later. So now looking at what was selected, the dose between 15 and 50 micrograms was chosen for expansion cohorts. So pretty wide therapeutic index here because we don't see too many toxicities, not seeing cytokine release syndrome at this point. So the exposure and potency is clearly depicted here. We see a percentage of cell lysis as we increase the dose, but between 15 and 50, there's not a big difference. The half-life of the drug is about 2 days. And as I mentioned, patients have daily injections, which are pre-filled and could be self-administered. So in patients that were actually treated with 15 and 50 micrograms in monotherapy, pharmacodynamic analysis revealed findings that were actually seen in preclinical model, including decrease in MDSCs, expansion of effector T cells by actually increasing granzyme B plus CD8, and also increasing cytokine and chemokines locally. Also, what was pretty interesting to see is that there is a polyclonal T-cell repertoire expansion with the treatment. So that's one patient who had relatively low T-cell expansion at baseline. And then, as you see here, cycle 4, day 1, there's a pretty large new T-cell clone expansion, which could eventually correlate with further anti-tumor activity. And as an example, in phase 1 monotherapy in solid tumors, that was a patient with metastatic ovarian cancer treated with multiple other lines of treatment. She already had previously pembrolizumab, obtained only stable disease with that. She was treated at 15 microgram dose, and actually after several cycles achieved a complete response. And that complete response was confirmed and was durable. So this is what you see here in the duration of treatment. The patient actually achieved a prolonged complete response. Also, a patient with poorly differentiated cutaneous squamous cell carcinoma treated at 50 micrograms had significant reduction in the occipital scalp lesion and improvement symptomatically with off narcotics and improvement in pain. In the part with combination of pembrolizumab, this patient, 92 years old, with high-grade urothelial carcinoma with pulmonary metastasis, obtained partial response, initially stable disease, then partial response over time. The tumor was considered PD-L1 minimally positive, and patient did not receive immunotherapy prior to being enrolled in the study. Also has a pretty long duration of response. So I think, with this medication, with this drug, as again, self-administered, pretty well tolerated, seeing some anti-tumor activity, we can clearly say that there is a way we can target the MDSCs and increase T-cell activation, and this way eventually having improved response, even for the patients who are not benefiting from PD-1, PD-L1 inhibitors, or in combination with immune therapies. So I'm going to move to the second drug that I want to discuss. That's a selective Axel-Mer CSF1R inhibitor from Curient. So this is a potent and selective inhibitor of all these 3 targets. Preclinical assays have shown that this drug has really selective activity against all these 3 targets, and in nanomolar potency, both in vitro and in vivo. And both, all 3 targets were inhibited at a similar range of concentration and dose, which is important for clinical studies. We don't have to increase the dose for achieving an inhibition of a 3rd or 2nd target. But as a one slide of background, Axel and Mer were first cloned from CML and LLC and recognized as proto-oncogenes several years ago. Increased expression of Axel has been reported in multiple tumor types, including lung, breast, ovarian, gastric, pancreatic, melanoma, and others, and of course leukemias, lymphoma. And increased MER expression was associated with leukemias, lymphoma, melanoma, and others. This expression of Axel and MER has been correlated with a poor prognosis in cancer, and particularly expression of Axel, and we'll see in the next few slides, has been shown to confer resistance to EGFR inhibitors, particularly in lung cancer. So for these 2 pro-oncogenes, the function is considered to be important in survival, invasion, and metastasis in a variety of cancer. But also, these 2 can inhibit the innate immune response, and they're expressed in dendritic cells and macrophage. So by targeting this 2 proto-oncogene, we can expect some decrease in survival and invasion metastasis, but also eventually an increase in an immune response. Also, in the same line of discussion, activation of Axel and MER limits toll-like receptor and cytokine receptor signaling. For the CSF1R, that has been used in several other studies as a target, is a gene that is altered in 1.4% of all cancer, or that's how it's considered, including lung, colorectal, melanoma, endometrial, prostate. This seems to have the greatest prevalence of alteration. And alterations could include mutations, frame shift insertions, and deletions. And that these mutations have been, alterations have been also linked to tumor expansion and increased survival. So for particularly this drug, the Q702, targeting all three Axel, MER, and CSF1R, it's important to look at the tumor microenvironment because most of tumor microenvironments have a sort of immunosuppressed phenotype with decreased cytotoxic CD8 T cells, decreased antigen presenting by loss of MHC1. But then once the tumors are treated with the Q702, we see a different phenotype with increased CD4 and CD8 T cells, increased antigen presentation, decreased tumor-associated macrophage, and decreased MDSC population. So looking at the anti-tumor activity through inhibition of these targets and immune activation, what we see actually is that this drug triggers a unique immune response in tumor microenvironment. If we look on the left part of the panel, sorry, right part of the panel, we can see the tumor volume if the tumor, that's a breast cancer syngeneic model, are treated with vehicle, and then Q702 and the two other drugs. The RXDX106 is actually just an Axel and MER inhibitor without the CSF1R, and it does have anti-tumor activity, as we can see here in red, but not as significant as the triple inhibitor. And also the pexidartinib, it's a CSF1R inhibitor, and we see anti-tumor activity looking at the tumor volume at the same level as the inhibitor of Axel and MER, but definitely less than the triple inhibitor, which is the Q702. Same here, we can see the CD8 positive T cells are highly increased compared to the other two lines treated with the other two drugs. Another important thing that a company look at is an increased interferon gamma that will enhance immune activation. And this is actually looking at patients with metastatic melanoma previously treated with pembrolizumab. They look at interferon gamma mRNA expression, and that was significantly associated, high expression was associated with overall survival of the melanoma patients treated with pembrolizumab. So here, if we look at the tumors treated with the Q702 on the panel on the right, you can see an increase in interferon concentration that is much higher compared to the two other drugs, as I mentioned, the Axel and MER inhibitor or the CSF1R inhibitor. Also, a combination of Q702 and anti-PD-1 antibodies showed significant tumor growth inhibition compared to vehicle, and also compared to anti-PD-1 antibody monotherapy in an EMT6 syngeneic model, and that is presented here with the tumor volume. If you look at the combination PD-L1 and Q702, that's the purple line, and definitely we see a decrease in tumor volume that is significant compared to the other comparators. And the drug, the Q702, was analyzed in vivo in various syngeneic models, including colorectal, 2 colorectal and 1 renal cancer model. And you can follow here also with the purple line, the Q702 has a significant decrease in tumor volume in this in vivo models. So regarding the Axel-dependent tumors, as I mentioned, overexpression of Axel has been correlated with poor prognosis through promoting epithelial to mesenchymal transition and also inducing drug resistance to chemo and particularly EGFR inhibition in patients with non-small cell lung cancer. So in this situation, if we look at this, the tumor volume in vivo models, we can see the tumor decreasing with erlotinib, but increasing again. But if we combine erlotinib with the Q702, we have a persistent decrease in the tumor volume. So we could say that eventually the tumors that are acquiring erlotinib resistance could have an induced reduction of the tumor after adding the Q702, and that could create a way to use this medication in the future in different clinical studies. So this study is just at the beginning, so it's an ongoing phase 1 study, dose escalation, looking at safety, pharmacodynamic, pharmacokinetic, and with the cohort expansion, that will be defined a little bit later. At this moment, we're still in the dose escalation. What are the next plan for this particular drug will be to look at expansions in lung cancer and also gastrointestinal cancer with the drug alone or in combination with immunotherapy like PD-1, PD-L1, and others. And looking, of course, at preclinical models more to identify the high Axel or more expression in different cancers and eventually combine with standard of care chemotherapy in other tumor types. So this is all I have for the time being. What I would like to just mention and what I see in our phase 1 unit is we do have several early studies with what I guess are considered first-in-human drugs, but we see more and more new targets and drugs aiming to increase immunotherapy effectiveness or to trigger immune response in various ways. So I think we start moving from just PD-1, PD-1, ICOS and others, and look into the MDSCs and tumor microenvironment and basically balancing cytokines and activating T cells. But I think we still have many questions about these drugs, how they would compare or demonstrate superiority compared to the current standard of care. What will be the toxicity profile? We see this in phase 1, but as we all know, there are always some toxicities that could appear later on, say in phase 2 and phase 3s, and additionally with the drugs that could be administered more on a chronic pattern. So what will be that toxicity? How would be improved? And especially in combination studies, I think we will see more problems eventually. I mean, all these drugs are definitely based on very serious and exciting science in the lab, in preclinical models. So I think it's very exciting to have these drugs in the clinic. I think the question is over time, where are we going to see these drugs? And then how can we do to guide future drug development and combinations based on the preclinical studies and not just have like a niche with working on one drug and another company works on another drug? How can we see the big picture of what's happening out there? So I will stop here. I think my time is off and I'm happy to take any questions, and thank you for your attention.
Well, thank you. That was wonderful. And I don't know if there are any questions here. Anybody's welcome to speak up. So I have a question for you. So with the immunotherapy drugs, are you seeing any biomarkers used for patient selection, or are they being applied more broadly within tumor types? What is your experience there?
Well, I guess what I can talk about is more the phase 1. So we have a few studies that are requiring selection, but it's like B7H3, for example. We need to have the target for that. And then we have a study with adenosine A and B inhibitors that they also require the target to be positive. But overall, if we have other, immune therapies like LAG3 or ICOS or, this kind of immune therapies, there's no requirement for selection. And we really don't know very well how to select the patients at this point, in my opinion.
Yes. Any other questions?
I have a question. The first drug trial, I am also very
Involved.
Interested. Can you hear me?
Yes, I can.
Yeah. Interested in the biology, and we were very encouraged by the CR seen in ovarian cancer. I did put many ovarian cancer patients on the trial, but yeah, I would definitely be interested in seeing how it unfolds, especially with the combination of PD-L1, and was just notified that the trial of the portion that's open in my institution is not moving forward, so remains concerned about what's going on. But yeah, I think the MDS, it just validates MDSC is a great target, whether it's this molecule or not. Yeah, yeah, it remains to be seen. But thank you.
Yeah, I work with another study with Regenix that also kind of indirectly target MDSC, and we've seen some results. We were also notified that the study, unfortunately, the expansion cohorts will be closed, and I don't know at this moment why. It could be maybe because they reached the number, or but I think there are more plans for continuing some other studies with this particular drug. So yeah, I didn't mention this.
There's a question.
I didn't want to decrease the enthusiasm because I still believe it's a good drug.
Well, sometimes drugs come back from the dead.
Right.
So they get resuscitated all the time.
Yeah.
And sometimes in a totally new form. So it's like reincarnation. There's a question from Jonathan Treisman. Do you expect increased IRAEs with MDSC suppression? And I think that's the last question we're going to be able to address.
Yeah, I think if it's just MDSC suppression, we could expect some increased immune reaction or adverse events. But this particular drug has shown not to have that many immune related side effects, possibly through the activation of T cells in the same time. But I guess combinations with PD-1, PD-L1 inhibitors, we should be aware that there is a possibility of increased immune side effects.
Okay, thank you again for that very informative talk and updating us on. And our next speaker is Dr. Centi Patel, who's the principal investigator for our famous START trial. And hopefully he's here and will give us an update.
Hi, nice to be joining everyone. Let me just get my slides going and hope let me display those in full screen. Hope everyone's doing well, and wish we're all doing this in person, but hopefully in the spring. And so it's my privilege on behalf of our entire team to be presenting some of the updates from DART. This is our study of ipilimumab and nivolumab across rare tumors. And what I hope to do is summarize some of the cohort data that has been presented kind of in a nice single package for everyone to review, and then stimulate some discussion around. For those who may be newer to the committee, let me, if it's okay, describe the reason we were doing this study. And so, in many of our clinics, we often have patients with rare tumors, sometimes tumor types, at least for me, I've not heard of before. And the question around, which disease team do they go to? And they often come into the phase 1 programs, of course, and they would often ask about immunotherapy, and even the quote unquote standard therapies for their disease aren't FDA approved in a randomized fashion. And so even the word standard is, italicized. And, one of the questions, in addition to doing genomics and looking for rare drivers for which we have targeted therapy, is also, what about immunotherapy? And we got asked this question quite a bit. And the answer is we didn't know. And so the idea was we wanted to investigate this. And it turns out a lot of people wanted to investigate this. And so when we talk about rare cancers, there's this belief that, it's, a couple percent of the population. But in fact, if you add up all rare cancers, it's almost a quarter of cancer burden worldwide. This is some EU data, but US data is similar. But equally important is the rare cancers represented by the blue line are more frequent in younger patients. So when you think about the burden of cancer to society, especially on younger patients, it really shows that these cancer types are a major unmet need. And one of the historical reasons it's been difficult to do studies in rare cancers is they really cut the gamut, right, across multiple tumor types. There are very few people or committees that will look at head and neck and, female genital tract cancer and sarcomas, right? This committee being one of them. And so, and CNS tumors as well. And so the idea that could we move the needle in the benefit of our patients and to help understand when immunotherapy can help and when it can be less helpful across a set of rare tumors became really the genesis of this study. And so these are all the rare tumors that are currently enrolled. We started with about 31 tumors here on the right, currently 53 rare tumor types as defined, on the left, and then currently 53 rare tumor types as defined here on my right. And really, you see as you look at total registrations on the right column, many of these quote unquote rare tumor types, they're, 17 patients with desmoid tumors, right? 22 patients with gallbladder cancer, 18 with angiosarcoma. And so the reason I wanted to show the data in this format is, one of the kind of tautologies in the field of oncology has been, well, we can't do rare tumor trials because they don't accrue. And then we don't try to, create and open rare tumor studies because they don't accrue. And so by definition, they're not going to accrue because they don't exist. And so the idea that we could try to move the needle and benefit for the patients. So the question really became, if we are going to investigate immunotherapy, what's the best form to do that in? And there's nothing special about common tumors responding to immunotherapy and rare tumors not. There'd be no, demographic basis for an immunologic response. And we see here actually two studies led by SWOG, PIs, right? Pembrolizumab and Merkel cell, led by our colleagues at the Hutch, and nivolumab and anal cancer, led by our colleagues initially at MD Anderson, now at Vanderbilt. And we see that in rare tumors that patients can respond to single agent immunotherapy. But the idea was for a single patient or a single chance at many of these rare tumors, right? As listed, we wanted to maximize our ability to find signal. And so the idea of using a combinatorial immunotherapy approach became attractive, but we wanted to balance the signal finding aspect of this study with the toxicities that can come from combinatorial immune checkpoint blockade. And so a lower dose of ipilimumab, 1 milligram per kilogram every 6 weeks was chosen. So if you treat melanoma patients, that's a higher induction ipilimumab dose, 3 mg per kg. If you treat renal cell patients, that's 1 mg per kg every 3 weeks. This is 1 mg per kg every 6 weeks continuous. So it's it's a long-acting insulin, right? And it's not quick on, quick off. And so the side effect profile is similar that way. And so now 53 cohorts in this rare tumor study. It's a Simon 2-stage design. If one of the 6 patients responds, we open the next 10. And if 2 patients out of 16 respond, we count that as a positive study. We have this nice website that keeps track of our accruals, as I showed earlier. And one of the cohorts that really kind of stuck out immediately, both in terms of accrual rate, but response rate as well, was neuroendocrine neoplasm. This is a very difficult set of tumors to have clinical trials on. There's a lot of nuance in the pathology. The pathologic criteria have changed in the past several years. And these cancers really originate in multiple organs. And given kind of the history of oncology is very much, derived from organ-derived treatments in terms of the cancer, oftentimes these are unknown primary. And so, thinking more about the underlying biology and kinetics of these tumors, there are many that are well differentiated, low grade, they have more indolent biology, the carcinoids, right? The typical carcinoids. And you have the poorly differentiated high grade tumors, lung, GI, unknown primary, which have a more aggressive biology and fewer treatment options. These are most commonly classified based on the primary site. And we see your pancreatic is a little different than lung and thymic. And so prior studies had shown a 5% anti-PD-1 monotherapy in high-grade neuroendocrine carcinoma. And so in this group, we had 32 eligible patients. PNETs were a different group based on the biology and the fact they have different antecedent therapies. About half the patients had high-grade disease and about half the patients had GI. Primary, the median number of lines of therapy were 2. And we saw here that where the cancer started, based on the path report, didn't really tell us who responded or not. Some patients had deep durable remissions. Other patients, unfortunately, had rapid progression given the underlying biology of the disease. But when we started looking at different parameters, it really became high grade were the patients that could have a response. Of course, high grade were the patients that had, because of the rapid nature of their cancer, if it didn't work, they had rapid progression as well. And that's what we saw here is high grade biology drove responses. And so if we look at that data, numerically across the cohort, the objective response rate is about 44% independent of primary site. And even for the non-pulmonary high-grade neuroendocrine carcinomas, because in pulmonary disease, the use of immunologics and lung cancer is described, still a response rate about 40%. I think more curious in terms of biology was that the low intermediate grade tumors had a 0% response rate. And so we really weren't moving the needle and benefit of those patients. And one of the key salient features of immunotherapy is that durability of response when you do respond. And we see the median OS for this heavily pretreated population with a very aggressive cancer, right? The median overall survival for a patient who's had 2 lines of therapy for high-grade neuroendocrine carcinoma is measured in months, right? And here the median OS is almost a year. And so anytime we're combining immunotherapies, we always got to be concerned about toxicity. The most common are fatigue and nausea, but the most common immune-related toxicities, which really can be attributable to this regimen, came really along the endocrine and hepatic axes. So the hypothyroidism and liver dysfunction were the main issues that we saw. We saw high-grade colitis in 6% of patients, no pneumonitis, and no grade 5 toxicities in this cohort. I should mention there are some limitations to this cohort as well as DART, writ large. We did not have funding for central pathology review, and so we relied on local pathology reports. Mitotic rate and Ki67 information were utilized. The post-translational studies at CMAX will include some pathologic confirmation and molecular characterization, which at least after the fact should be helpful and maybe can help us discern which of those high-grade patients that respond versus have continued progression of their disease. And also local adjudication of organ of origin. I should mention Dr. Chai is going to be talking a bit more about the CMAX initiative, which is actually underway as we speak, looking at translational objectives from this cohort as well as others from DART. And that, our high grade versus low grade analysis was not pre-specified. It was really something that was just really stark when we looked at the data. We didn't know a priori there'd be a difference between low grade and high grade responses. And it's a single arm cohort, it's not randomized, 32 patients. And so one of the beauties of a platform study like DART in rare tumors is that you can make a dedicated high-grade neuroendocrine cohort. And we see here 19 patients with high-grade neuroendocrine neoplasms just with high-grade, and we're able to verify all these patients are microsatellite stable. So it's a completely separate, distinct cohort of patients. The objective response rate was 26%. The 6-month PFS rate was 32% with durations of responses greater than 10 months. And again, safe in the sense no grade 5 toxicities, and actually this time grade 3 dermatitis was the most common IRAE. When we look here at the overall other adverse events from an immunologic standpoint. In terms of high grade, we had high grade lipase elevation, as mentioned, rash, but really otherwise well tolerated for the vast majority of patients, and the lipase increase was not associated with frank pancreatitis. And then we look at the response summaries, 26% with PR, 5% with stable disease greater than 6 months. And so, about a third of patients are deriving benefit from this regimen. And now these are all patients with high-grade disease. We see here, regardless of their primary site, we have a cohort of patients that respond and have durable responses, but we also have a cohort of patients, apologies that the y-axis on the top half didn't translate well on this slide, but basically go to 100% and greater growth. And so the question really is, what separates these patients biologically, and are there biomarkers that can help us understand this? And Dr. Young Chai will talk about this momentarily, but these are the analyses that are ongoing with Cmax. As mentioned earlier, one of the main features of immunotherapy is patients can have prolonged and durable remissions on immunotherapy, and we see, regardless of the primary, that those patients with high-grade disease can respond. And so, focusing on neuroendocrine, but a bit of a halftime kind of update on the study. This is the first and only NCI-funded rare tumor immunotherapy basket study. We have 53 now tumor types, over 760 accruals, and we saw some really interesting data in high-grade neuroendocrine. But the question on what separates those patients that respond, or which patients that do not with high grade, I think is an important one, and one that translational analyses will hopefully help us. These studies in rare tumors can sometimes accrue quite rapidly, right? So this high-grade cohort accrued in 8 weeks. We had 21 accruals in 8 weeks. And the clinical benefit, while the objective response rate is 26%, the clinical benefit rate was about 1 in 3. And so it doesn't stop there, right? There are many cohorts that are of interest, some in surprising ways, some in really interesting ways. And so this is a study Dr. Wagner proposed and led from the Hutch, and this looks at angiosarcoma, which is a tumor type that is also quite heterogeneous. You can get it on the face and scalp, you can get it on the breast. They're cutaneous, they're non-cutaneous manifestations, and you see here on the left waterfall plot that the responses typically were in patients with cutaneous angiosarcoma, especially of the face and the scalp. Though that wasn't universal, there are patients with those that had progression. And so yet again, kind of like the high-grade data, really a bimodal distribution with elite response, but then patients that did not. And so this is another area that translational analyses, which are ongoing, I think, are going to be really informative. Metaplastic breast cancer, right? Not so metastatic patients, but metaplastic breast cancer are tumors that effectively have de-differentiated slightly. Think of it like a breast teratoma, so to speak, that has recapitulated multiple pathologic subtypes. Generally is a poor response to cytotoxics, frequent overexpression of PD-L1, and really a dramatic response to PD-1 blockade. And so the idea that this could be a cohort, this is actually a patient on the study, and as you go through the alphabet, you see the really dramatic response, and you see the PET response in the bottom right. And so this with immunotherapy, the chemotherapy responses are just not robust here. And so when we look at the data in aggregate, yet again, we have patients with deep, durable responses that are long lasting, as you see on the Summaries plot. And even when we get into the specific predominant metaplastic subtype, we don't see a clear signal, whether it's chondromyxoid or spindle. Meanwhile, you have mixes of chondroid and spindle that don't have similar responses. So it's not clear that the pathologic correlates are informing us which patients will respond or not. Likely, once again, it'll be a molecular immunologic correlate. And this is one of the groups we're looking at in Cmax as well. And so amongst these 17 patients, 3 of the 17 actually had really nice responses, as you can see, both in the waterfall plot and the Summaries plot. And the question is, what makes them unique is something that's actively being investigated from a translational standpoint. And so I won't spend too much time on this because Dr. Che will be focusing on this, but broadly, we're currently collaborating with Dr. Westuba at MD Anderson on doing Cmax-based analyses of these cohorts and really trying to discern what are the salient molecular and immunologic differences amongst patients that respond and not. And secondarily, aside from kind of predictive biomarkers for immunotherapy, sensitivity and resistance, also really trying to create a TCGA of rare tumors, so to speak. Many of the tumor types that we've studied don't have robust molecular data. And so the idea that if we can find recurrent molecular abnormalities that may be targets for future clinical trials is something we're keen to do. And so I'll have Dr. Chai focus more on this, but the idea that there's a variety of assays for us to choose from to really investigate the biology and try to separate and understand, why some patients have deep durable responses and some do not. And so broadly, we've seen that ipilimumab and nivolumab in combination have durable and deep responses in a subset of patients with high-grade neuroendocrine angiosarcoma and metaplastic breast cancer to date. But I think, one of the bigger concepts, hopefully, that comes from this study is that clinical trials in rare tumors are feasible. This study is open in 800 sites throughout the country. As many are aware, it's not particularly easy to open clinical trials, especially during the pandemic. And so the idea that there's this much interest, especially in the community, I think is key. 2/3 of the patients, at least in the neuroendocrine cohort, were treated in the community setting. And so the idea that we're seeing the tip of the iceberg in many academic settings and really getting the trials out to where the patients are, I think is so key. We've had over 770 accruals in the past 3 years across these 53 rare tumor cohorts. And the kinetics on accrual, as you've seen, can be quite robust. We can answer these questions quickly to benefit our patients with rare tumors. And as mentioned earlier, these are often younger patients. And then you'll hear more about the correlative analyses, because one of the keys we want to be able to say in the clinic is, the probability of response or not. And we see kind of this sink or swim aspect in multiple waterfall plots in this study. And so the idea, can we, figure out which patients will confer the highest benefit? And so really just want to thank my co-leads, SWOG colleagues, everyone who's involved in the study, the statisticians, the data coordinators, everyone at CTEP, everyone we're collaborating with CMAX, and of course, most importantly, patients and their caregivers. And if we have time, I'm happy to take any questions.
Well, thank you for that beautiful presentation. And the study is going extraordinarily well. Are there any questions? There are some questions in the chat if you want to look at the chat, Sandeep. And I can read them to you, or you can look at the chat and repeat them.
Sure, happy to. I just opened it. Sorry, everyone. So I think the first question, that was from the earlier session. Did we pre-plan sample acquisition analysis or did it evolve after high-grade net? We always find it difficult to do TM after trials have enrolled. Thank you for the compliments and your own work in this field and broadly in melanoma. And so I think for us, we pre-specified archival tissue and blood collection. And we had ideas on what we could do, but the CMAX opportunity actually didn't materialize until about a year into the study. And Dr. Shea will talk more about this. Basically, we wanted to bank the tissue and the blood with the idea that we were going to do these analyses. And then it turned out with the CMAX initiative, there were even more analyses that we could do above and beyond what we initially planned. And so I think the key with any protocol, and as you've led, Dr. Patel, yourself, many of these in rare cutaneous malignancies is really around banking. And then what happens is the science evolves as the study is ongoing, and you can do even more with the samples. But it's absolutely a great point that it can be difficult to do TM after trials have enrolled. The flip side is I've found a lot of people are very interested in those specimens, though, whether it can be formally done within CMAX or not, that's really a question from an operational standpoint. And let's see, are more arms opening, such as chondrosarcoma? So I would love a chondrosarcoma cohort. I would love a sarcoma cohort, but both along the sarcoma cohort axis, given that there's a dedicated immunotherapy study there, as well as we've kind of ballooned from, I think, 32 arms to 53 arms. From an NCI standpoint, 53 will be our cap, and there may be future studies that hopefully benefit these patients. Oh, Dr. Patel's following up. So CMAC has been able to work with your bank samples not needing fresh collections. Yes. So the archive, actually, in fact, all our tissues are archival. We unfortunately did not have funding for de novo biopsies on the study. And so probably, and Dr. Che will be talking more about this, I think probably about 60 to 75% of our analyses are tissue-based, based on the paraffin samples that are archival from local sites. And one of the inclusion criteria for the study was, I believe, on the order of 15 to 20 slides or equivalent. The blood had to be pre-specified, as you could probably imagine, because those samples had to be studied at Children's National, I believe, and Dr. Che will talk more about that momentarily. And then Dr. Davis, yeah, absolutely. I think, she leads the sarcoma working group, and obviously anything that can help those patients, any concepts related to immunotherapy otherwise would be great. And I'm glad to help to make the connections between Doctors Victor and Davis there.
Yeah, there's a comment there. I did not realize we had a sarcoma working group. So to all, we have a sarcoma working group that Dr. Lara Davis leads, and she's actually going to talk about it after the next speaker. Dr. Patel, I had one last question for you. I thought that those were great slides on the metaplastic breast cancer, and I thought that cohort was particularly interesting because of the dichotomy in responses. So it was unlike other cohorts. And of course, there could be a bias because of the limited number of patients, but it was all or nothing. There are 3 patients that have exceptional responses. They're ongoing responses at 30 to 34 months or about that. And then the other patients have nothing. And that's really different than what we saw, let's say, in neuroendocrine or even in angiosarcoma, where there's a whole spectrum of responses. So what are your thoughts there? Do you think that's because of the limited number of patients, or there's an on-off switch peculiar to metaplastic, or what do you think?
Yeah, it's a great question, and I would be remiss not to mention that you've led many of the studies with anti-angiogenic agents in this space. The Dr. Seuss regimens, I think, as you like to call them, in addition. And so my sense on this is, if you can have a great drug like trastuzumab, or right now trastuzumab deruxtecan, but if all your patients are HER2 negative and ER positive, your curves aren't going to look that good. And so here we're looking at tumor-facing pathology for drugs that are immunologically active. And so whatever T cell signature or MDSC, as mentioned earlier, or NK or macrophage signal that's present in these 3 patients is something we hope to discover with the Cmax analyses. But my sense is different tumor types have a differential distribution of these immune sensitivity signatures, right? And so it's likely that high-grade neuroendocrine carcinoma has a higher preponderance of whatever that signature is relative to metaplastic breast cancer. But what that signature is that dichotomizes, I think, is a mystery. But I think us focusing on where the tumor is kind of tunnel vision, right? Because these drugs all work on the immune stroma. And so these stromal translation analyses, and hopefully in the future, biomarkers of what the stroma is telling us immunologically will be key, similar to how next generation sequencing has revolutionized our development of targeted therapies by elucidating the genomics. Here, we're staring at the tumor, but it's actually the immune microenvironment that we're trying to act on. And it's no wonder that we're missing on the biomarker side so much.
Okay, well, thank you. Thank you for that wonderful presentation, and also for leading this really phenomenal trial. And also, I think one of the things that I love about the trial is also giving an opportunity for other investigators to lead particular arms. As you mentioned, Dr. Michael Wagner, angiosarcoma, and Dr. Sylvia Adams, the metaplastic breast cancer arm. So I think we should move on at this point to Dr. Young Chai, who is the vice chair of our committee, and is at Northwestern. He's going to talk about the translational components of DART. He's done a phenomenal job building the translational components out. So, Dr. Yang-Chai, it's yours.
Thank you. Thank you for the introduction. Do you hear me okay?
Yes.
All right, great. So we talk about the translational medicine aspect of the DART trial, SWOG-CMED collaboration. So these are my disclosures. We talk about the objective and the background evidence for the TM in this combinatorial immunotherapy space. We talk about the academic as well as commercial collaboration ongoing for this trial. So these are the trials that led us to think about the immunotherapy combination approach, one from the renal, one from melanoma trial. And we are using actually the Checkmate 227, the regimen, which is in the lung space. So here's the sort of the grand scheme of why we're doing the TM, exploring the unknown in this rare tumor space. What is the genomic immune landscape? What is the response rate? What is the predictor of this response, potential responses, and the predictor of immune-related toxicities, which kind of came on as later outcome analysis we are planning to do. So 4 pieces: genomics, transcriptomics, immune cell composition, as well as proteomic change. So so the birth of this DART trial was sort of following the NCI match, which focuses on addressing the unmet need in rare tumors. In fact, 1/4 of all the participants in NCI match trial were rare tumors. And they really didn't have any place to go when they didn't match to any particular targeted therapy arms. So when we created DART, the initial arrangement was that for the ones that screen failed or was getting treated on NCI match and then screen failed for the next arm were to be screened for DART. And later on, when NCI match was closed for in-house matching, we were sort of standalone thereafter. So this is the initial TM workflow of the match. So we do have access to their initial specimen that were banked in the this was an ECOG-ACRIN bank, and though we do also have access to the all the database that was generated from the sequencing efforts. So this is the initial data, biomarker data from NCI match. They do have the Oncomine NGS panel data, along with some selected IHC and FISH. So we're going to talk about some background idea or hypothesis behind why we're doing what we're doing. So the basic concept is that the genomic stability, whether it's defined by the DNA damage response gene aberrations, such as MMR or HRD or POL-ED, or the PARP pathway deficiency, or overall characterized by the high TMB, whether that genomic stability or instability is linked with response to immunotherapy. And it has been sort of replicated in many different histologies. This is the sort of the very initial TMB and outcome correlation described in the non-small cell lung space with single agent immunotherapy. And this is the schematic flow graph of objective response correlating well with somatic mutation burden across different histologies. And yeah, there seems to be a nice correlation, but the caveat is this is the objective response rate, not the overall survival. So MSK group looked at the overall survival amongst their clinical trials that enrolled different histologies treating with same immunotherapy approach, and did find correlation with the level of TMB and overall survival, as you can see in the figure left upper corner. And then what are the specific histologies or the regimens that were related to favorable overall survival outcome. The subgroup analysis is presented on the right side, but it does look like there's a trend for a higher TMB linked with better overall survival. So this brings us to the larger trial, first in melanoma, then in non-small cell lung space, first showing that in high TMB, the nivo seems to do better than chemotherapy in terms of PFS, but later on, overall survival did not pan out to be any different. This is a prospective trial enrolling all first comers treated with atezolizumab. Looks like response rate, there is a nice positive correlation with higher blood TMB correlating with better response. But later on, if you look at the middle curve, overall survival did not pan out to be much different. But that's lung cancer. But bladder cancer, as you can see in this two different trial, seems to have positive correlation between high TMB and overall survival, as you can see in these two trials. So the thinking is that maybe the correlation will be different histology by histology. And in our DART trial, we have many different histologies, so it remains to be seen whether across different histologies there will be the same association or not. Now, thinking about the combination, because the other data were all coming from the single agent immunotherapy, what is different? What becomes different if you do a combinatorial approach? So here is nivo-ipi data showing that higher TMB might be linked with better PFS and better response rate. And within high tumor mutational burden lung cancer, you do see that overall survival is better compared to chemotherapy. And regardless of PD-L1 positivity, the benefit does remain significant, nivo-ipi versus chemotherapy. So if you look at the subgroup, PD-L1 level and TMB level, it really doesn't affect the benefit of nivo-ipi, which actually plays in favor of our trial. Regardless of markers, perhaps the combinatorial approach is going to be beneficial. So so we do have pan-tumor TMB high approval of pembrolizumab based on the Keynote 158 trial, and here the cutoff was the TMB of 10, and it did accrue a lot of different histologies, including some of the rare tumors. So that's why I'm presenting this data, because it has some similarity with our DART trial. And here, as you can see, the blue is the one with high TMB, red is the one without high TMB, and there are nice responses seen, and overall response rate does correlate with the high TMB here. But for the responders, the survival doesn't change much differently between the two groups. What's important is PD-L1 status and the TMB status are really independent of each other, orthogonal, or and doesn't really correlate. And that's been sort of a repeated theme across different trials, looking at biomarkers. This group sort of published this article with provocative statement, but what it really means in some cancer types, TMB burden does not predict good response to immune checkpoint. That's what it is. And they categorize groups in category 1 and 2. 1 is CD8 positively correlating with neoantigen burden. Category 2 showing no correlation there. And if you look at the bottom, category 1 is colon melanoma, bladder, and uterus cancer, as well as the adenocarcinoma. What's interesting, squamous did not correlate, did not belong in category 1. And they show that the response rate or the overall survival really did not play in favor of TMB high group. And the prime example might be the breast or glioma case where the immunotherapy treated group had inferior overall survival. So this is, something to remember, that in some tumors, TMB does not work in favor. But again, this is coming from just the composite of different clinical trials, and with different agents, I think the association may be different. So what happens with the chemo plus immunotherapy? The keynote 21189 shows that TMB does not really play a big role in this space. And then switching gear to genomic traits here, we have small cell lung cancer histology showing that overall survival may differ by TMB, unlike non-small cell lung cancer. And then it's beyond TMB, we really need to look at where are the mutation. Is it in JAK1/2 or beta microglobulin or HLA class difference? So these do affect the response to immunotherapy. And we are also looking at chromatin remodeling genes and many other epigenetic regulators. There are nice examples of how those mutations will affect the outcome of immunotherapy trials. And what's interesting, the frame shift indel would lead to 3D conformational change in protein. So this might be one of those more immunogenic neoantigens. So the jury's out there, but the current school of thought is that the quality of neoantigen does matter, and frame shift indel mutation burden may be different than point mutation burden. And this is a study that my group did that showed that having FS indel does predict better outcome with immunotherapy, including better survival and response rate within non-small cell lung cancer, and does correlate with TMB changes. We are looking at PD-L1, and Dr. Kurdrag's group have shown that 0.7% prevalence of PD-L1 gene amplification is found across different histologies. And the data shows that the single agent immunotherapy was showing a 66% overall response rate. Therefore, we've created a new cohort in the amended protocol with including common tumors that have PD-L1 gene amplification. And this cohort will be treated with nivolumab monotherapy. We are looking at germline as well, and we are expecting that these genes may be a little bit more frequent in rare tumors. We are looking at RNA-based signatures, and there are many different signatures out there like IPRES or TIDE or just 3-gene signature or the chemokine signatures, and they've all been sort of linked with difference in survival. But it remains to be seen what becomes more relevant in collection of rare tumors in our cohort. Also, we're planning to look at HLA subtypes, transcriptional loss, and one prime example is coming from Empower 150, where they look at just only 3 different genes, PD-L1, CXCL9, and interferon gamma, and came up with a T effector cell high or low signature, which did correlate pretty well with differential survival when treated with first-line atezolizumab in lung cancer. We're also looking at ARI2, PBRM1. These genes have also been linked with differential outcomes. Also, we're measuring the different immune cells through CyTOF, as well as the multi immunohistochemistries we're going to be doing with CMAC. And as far as the PD-L1 is concerned, we are doing the DACO 28-8 IHC. And as you can see here, I think by PD-L1 may affect the outcome of the combination, but it will be different by different, vary by different histology. That's the key. We are looking at proteomic signature from blood, and we'll be using MALDI-based proteomic signature. And there are some data out there, mainly from a melanoma space, where the combinatorial immunotherapy response and survival outcome has been linked with the MALDI-based proteomic signature, as you can see on the right side. So I think this is important because we're looking at host factors. We're not looking at proteins that are shed from the tumor itself. Majority of them are produced by our liver. It's acute phase reactants. They are mostly host serum proteins. So we are looking at the host factors. In addition to the germline mutations, I think the proteomic markers will definitely shed light into the host biology, the importance of it in predicting response. So all these different angles, are we looking at this as like a one all intertwined composite, meaning is there orthogonality or is there a bottleneck? I think the data coming out from different trials, for instance, Keynote 208, looking at pembro in different histologies, they did find that T cell inflammation signature coming from the gene expression signature and PD-L1 level, as well as the TMB, they do not correlate. There's no correlation. So they are orthogonal. They are independent of each other. We do see that maybe with the combination therapy, if you have low TMB, then PD-L1 level might matter. And that's coming from the lung map study. It did not show any difference after the failure of immunotherapy, nivo-ipi versus nivo. Was there any benefit of giving combination? As you can see, there was no meaningful difference between overall survival or PFS in this space. But with the caveat of smaller sample size, if you have PD-L1 negative, maybe high TMB, this is a left side graph, might show better survival with nivo-ipi compared to nivo. So this is just a thought. But what's interesting in Checkmate 227, which uses the exact same regimen as our DART trial, shows that it works regardless of different level of TMB or PD-L1 within lung space. And we now have 4-year overall survival outcome, which is very encouraging for someone like me who treats lung cancer mainly. And then 4-year survival is like 29% versus chemo 18%. So this is what we still consider very durable response with chemo sparing agent. And that 4-year survival rate goes to 37% with a higher PD-L1. And even in PD-L1 negative group, it's 24% versus 10% in chemo. What's really interesting is people who experienced immunotherapy side effect and had to stop the treatment did maintain very good durable survival outcome in this group, whether they are PD-L1 positive or negative. The 4-year overall survival rate for people who stopped immunotherapy were still like 44%, which is very encouraging. And we would like to see this kind of data replicated in our DART trial. So about the bottleneck, yes, I do think there's a bottleneck. Even if you have the highest TMB, highest PD-L1, the best signature, if you have a defective internal immune machinery, like mutations in JAK1, or beta-2 microglobulin, you will not have response to immunotherapy. So understanding the internal immune interferon gamma pathway, the defect in the machinery is also very important. And also understanding the subclonality of the tumor, not just the TMB itself, is also very important. So we have incorporated the blood sample about close to a year after the trial started. So we amended the protocol to have mandatory blood collection at 3 time points: at baseline, at the first imaging, at the progression of disease. So with the aim to look at all these blood biomarkers, including ctDNA and cytokines and proteomics. So this is the initial scheme that we started when CMAC got involved with DART. And you can see Biodesics is our partner for proteomics. Circulogene was our initial, but I'm happy to announce that the CMAC, the Stanford laboratory, has offered to do the comprehensive ctDNA analysis with ctDNA, since Circulogene is not offering this, the blood TMB at this time. So this is our industry initial collaboration. We started with the JAX collaboration. We did not get the grant funded, but with the pilot CMAC grant, we were able to be the first selected immunotherapy trial for this project. So we're very excited. As we speak, the first pilot cohort analysis is being done, and the clinical correlation is being conducted. And these are the assays that are being conducted as part of the CMAC, and only the protein assay has been outsourced to Sinai. Most of them are being done at MD Anderson at this time. We've also added the TCR clonality analysis for at least the first 3 cohort of the neuroendocrine histology. And the CyTOF, the O-link is being done at Sinai. The Stanford is doing the CyTOF and the ctDNA analysis. And the rest is being done at the MD Anderson CMAC core lab. So this is the schema. All these data generated from the laboratory, as well as the our outcomes data generated from SWOG, will be going to the CIDC, Cancer Immunologic Data Commons at Dana-Farber Cancer Institute. And our clinical team will be communicated with CIDC to sort of analyze the data, which is being done for our pilot project, which is the 3 neuroendocrine data. So we've prioritized groups into pilot 3 cohorts, which are the neuroendocrine, and we prioritize the groups with at least 2 patients with objective response, and the groups with at least 1 objective response. So currently we did up, like I said, the Cfdna Dna approval was what just happened for the Stanford Cfdna project. And what's interesting is we're doing the ultra low pass whole genome sequencing first, followed by whole exome sequencing. So we'll be able to look at the TMB. We'll be able to look at different clonalities and be able to, since this is not a targeted approach, we'll have much more information coming from the ctDNA approach, since not all the collected tissue samples are adequate for NGS. And as I said, TCR-seq is being done. Currently, the neuroendocrine 3 cohorts analysis using the multiplex IF, nanostring, WES has been done, and we are at the last step of generating the correlation data. The next cohort that will go into the analysis will be cohort 26 thyroid, 36 metaplastic, and 51, which is angiosarcoma. We're very excited that this will be ongoing pretty soon. Yeah, so we'll hopefully have some preliminary results to present on our next SWOG meeting, but kudos to everyone who's involved in this vast task of exploiting the landscape genomic and immunologic landscape of our rare tumors. Would like to thank our co-leads and all the SWOG team, CMAC team, and everyone involved in this ambitious project. Thank you.
Well, Dr. Chai, thank you so much. This is an incredible project. And I'm afraid that we've gone a little bit over time. And so I'm going to cut the questions, but anybody who has questions can privately write to Dr. Youngchai. I mean, what he's done with these correlates is absolutely phenomenal. So our next talk is going to be by Dr. Lara Davis, who's at the Knight Cancer Institute and who is leading our sarcoma working group.
Yes.
Dr. Davis, go ahead. Thank you.
Thank you very much. Thanks for inviting me to present some updates on the activities of our nascent sarcoma working group. We formed about a year ago with dual goals of championing and helping to develop protocols put forth by other NCTN groups, as well as, of course, developing our own SWOG-led sarcoma concepts. And over the past 6 months, since the last time I gave an update, we've reviewed 4 children's oncology group sarcoma concepts. I will highlight that AOST 2032 is a concept for newly diagnosed osteosarcoma. SWOG champion is Dr. Andy Livingston, and it will be open up to age 40. It should be opening early next year. And ARST 2031 is for newly diagnosed metastatic alveolar or embryonal rhabdo. It's looking at using vinorelbine instead of vincristine in the backbone to reduce neuropathy, and that will be open up to age 50, with SWOG champion being Mingui Pan. There have been a couple of other earlier in development concepts we've discussed as well. I want to spend the majority of time today. Of course, we don't have much time, and I want to try to stay on agenda. I'm really excited to report that Dr. Wagner's concept S2208 of neoadjuvant immunotherapy for angiosarcoma was approved by the executive committee just a few weeks ago. It is building from a strong DART efficacy signal that you have already heard about so far today. So in this study schema, well, first I'll remind folks, because I forget I'm not talking to a purely sarcoma group, that angiosarcoma is a rare and aggressive sarcoma. Treatment for localized angiosarcoma varies pretty significantly center to center, but neoadjuvant paclitaxel is often used. And there's increasing evidence, including from DART, that angiosarcoma responds well to checkpoint inhibition. So S2208 will randomize patients with localized angiosarcoma to either standard of care paclitaxel or investigational paclitaxel plus nivolumab for 3 cycles or 3 months prior to definitive local therapy. Again, because there is a lot of variability there, that whatever that investigator choice is for definitive local therapy will be acceptable. Patients are who were assigned to the combination arm for neoadjuvant therapy will then complete an additional 9 months of post-op nivolumab monotherapy. So based on published historic event-free survival rates, we assume that the 1-year EFS with paclitaxel, the null hypothesis, will be about 50% at that 1-year mark. So this study is designed with power to detect an alternative EFS in the experimental combination arm with a 1-year EFS of 70%. And we have built in, with the help of Megan Orthus, a futility analysis at 50% of expected events, so about 30 events after approximately 1.5 years into accrual. And that'll be for futility. And based on the accrual rate on DART, we actually anticipate, even though this is a rare disease, 3 to 4 patients per month will be able to enroll. Secondary endpoints on this study will include RECIST response prior to local therapy, metastasis-free survival, overall survival, and pathologic complete response rates. And congratulations to Dr. Wagner on triage approval on first time through, which is pretty exciting. I've put his contact information here at the bottom if anybody has feedback or wants to get involved. I'm going to cover a few different concepts in a short period of time. I have put everybody's emails at the bottom of the slides, so please reach out to us and get involved at any time. So the next concept that we are developing is an abemaciclib plus or minus immunotherapy for advanced dedifferentiated liposarcoma. This is a concept put forth by Minghui Pan. And it's building from strong efficacy signal for abemaciclib monotherapy, of course, presented by Dr. Dixon and the ongoing SARC-41 trial. And so our study capsule for this is in progress. We're actively developing this concept with changes in response to feedback occurring regularly at our meetings. So as currently envisioned, we will enroll 140 patients with advanced dedifferentiated liposarcoma that will be randomized 1-to-1 to either abemaciclib monotherapy or a combination with pembrolizumab. And this will provide a timely and hopefully exciting follow-up to the current SARC-41 trial of abemaciclib, and also playing off of the prior data from SARC-28 trial of pembrolizumab. So we expect accrual across NCTN should be complete within 2 years, even though this is a fairly large-sized study in sarcoma. And the abemaciclib monotherapy control arm is expected to have a median PFS of 30 weeks. So our stats are based on a clinically significant improvement to 46 weeks, is how we've come up with this size of study. Again, any feedback, please reach out to me or Minghui at the email here. The next concept that we are developing is led by Hari Deshpande from Yale with immunotherapy for advanced radiation-associated sarcoma. For my radiation colleagues, it's sometimes called radiation-induced sarcoma, but radiation-associated seems slightly less accusatory, because we know how important you are in the treatment of sarcomas. And this is building on evidence of relatively high tumor mutational burden in these tumors, and as well as actually extrapolating from the efficacy of immunotherapy in UV-induced cancers. And so the study capsule is in progress at this point. So Dr. Deshpande has taught us that radiation-associated sarcomas present 5 to 15 years following radiation treatment for another cancer, and unfortunately have a prognosis that is substantially worse than sporadic sarcomas. So this concept's in the early stages of development, but we are envisioning a DART-like basket trial with 3 two-stage phase 2 trials put all in one for different RT-associated sarcomas. So that could be angiosarcoma, as we've discussed. Certainly post-breast cancer radiation, angiosarcoma happens not infrequently. And as well as non-angiosarcoma, soft tissue sarcomas. So having another basket for that, as well as bone sarcomas, radiation-induced bone sarcoma. And each one of these trials would be in 2 stages, but enroll up to 18 patients in each basket, with a 30% response rate being considered clinically significant. And finally, this concept led by Jeremy Harris from UC Irvine is looking at short versus long course radiation for high-risk extremity soft tissue sarcomas. Early in the concept phase. In fact, it was just presented last month, but Jeremy has made remarkable progress already. The concept is a admittedly large randomized phase 2 study with arms for both chemotherapy eligible and non-chemotherapy patients, with a design that is similar to the Pasnitz ARST 1321 trial. So that was the trial that looked at pazopanib in this same population, but the randomization is with the radiation dose rather than plus or minus pazopanib. So the idea being hopefully avoiding or transitioning from a 25 fraction standard regimen down to a 5 fraction, much easier, much faster regimen. And there would be also an arm for patients with smaller high-grade tumors that would of course not be getting chemotherapy. The goal here is a shorter course of radiation, which would obviously reduce treatment time, probably reduce toxicity, and importantly reduce health disparities, particularly with the rural-urban divide. And this concept will undoubtedly open up many cans of worms, as many of us in the sarcoma care often have to practice art over science, but there's a strong need to address this question. It's a question that's been brewing for many, many years, and so we're looking forward to developing this trial further. I am actually on time, I think, so I want to hopefully have a moment for questions. Dr. Patel, we do in fact have a sarcoma working group. We would absolutely welcome you and anyone else who's interested. Just reach out to me at this email address, and we have another meeting coming up next month.
Well, thank you very much, and thank you for leading this and taking the time. And I will open up to questions.
I'm going to take a quick second to make sure that I recognize Marsha Horn as our patient advocate, who's attended every single meeting this year. Really appreciate that, and Megan and Eddie from Stats, and then of course Dr. Ryan as our executive officer has really helped champion that Dr. Wagner's concept through executive committee. We appreciate that.
Yeah, I'll jump in if I can, or maybe we have a few minutes for discussion, or we can take this offline too. And we really want to give the best chance of the angiosarcoma of getting through CTEP. There was some concerns at the executive committee regarding the design, and I think we should think through that. It's a 2-arm study with the assumption that neoadjuvant Taxol is standard, and I'm not sure that's considered standard across the board. So there's questions. We make this a definitive study with a 3rd arm, no neoadjuvant therapy, or do we design this as kind of 2 experimental arms? So I think we need to work with our statistical group and some discussions about that. And the other issue is that this combination in the metastatic settings, current focus of an alliance trial. So the results of that could influence whether this moves forward or not. So we may want to do some reconnaissance mission with CTEP, and I don't know if anyone has put out any feelers with that about this. It's a little difficult with sarcoma because there's not a steering committee. There's often ad hoc reviewers at CTEP or the immunotherapy group, but I think we may want to put some feelers out there. Brazil, I don't know if you have any thoughts about that we should approach. This is kind of building on DART. So our DART friends at CTEP might be helpful to make sure we grease the skids. I don't want to get the CTEP and then it's rejected and we put all this work in. So
yeah, that would be appreciated, Dr. Kurzrock, if maybe we could leverage our CTEP DART connections.
Okay, thank you, and thank you for those comments. I think we're right on time. So Dr. Davis, thank you for leading this and also for keeping us on time. And so we're going to now move on to our next working group. And that's Dr. Manmeet Ahluwalia. And he will update us on the CNS working group update.
Good afternoon, everyone. Thanks, Dr. Kozrov, for the kind introduction, and excited to report on our CNS working group and follow what Dr. Davis and her group is doing in sarcoma. So big kudos to her. And again, huge thanks to Dr. Kozrov for allowing us to give our update, but more importantly, also supporting our working group. So we have a very multidisciplinary group, neurosurgeons, medical oncologists, radiation oncologists, working with neuro-oncologists, with allied healthcare people, collaborating with basic scientists, and we use the resources from the rare tumor committee in terms of statistical support. So as Dr. Davis had alluded to, since we are obviously relatively a young working group, less than a year old, our intent is the same, to develop concepts in our group, but also to be able to champion what is going on in other groups. So this is a Maverick study. It's actually a SWOG study, S1827, which is being led by Dr. Chad Rustovan through SWOG in collaboration with the group at Alliance, where Dr. Paul Brown is the champion. And the study basically is looking at a very important question in small cell lung cancer, and that is the role of prophylactic cranial irradiation. And the trial is actually a randomized phase 3 trial. It's looking at a question of brain surveillance versus after PCI versus just brain surveillance with MRIs. As you are aware, PCI has historically been associated with decreased brain metastases and has shown actually a survival benefit in the patients with small cell lung cancer following 2 landmark studies. However, this is fraught with neurological toxicity. So clearly, on one hand, you gain, but you have to pay a price for it. And so the question is, can we do better with the new era? Can there be MRI surveillance allowing for early salvage therapy for brain mets? And that way we may avoid PCI and its associated toxicities. NCCN now actually categorizes PCI as optional in extended stage small cell lung cancer and recommends MRI surveillance for all patients regardless of the PCI delivery. This is the NCCN guidelines, basically showing the MRI is a preferred modality for essentially doing surveillance. But a lot of patients are obviously getting this definitely for limited stage small cell lung cancer as a standard option for extended stage. So this is the schema of the trial, which is being led out of SWOG, and obviously, we have Dr. Chad Rustovan has been an integral part of our CNS working group and has been a great partner there. So the trial is basically small cell lung cancer, limited or extensive with no prior brain metastases, no brain metastases on MRI after first line therapy. They could actually go on to get either PCI, which is done quite commonly in practice, or no PCI with a brain MRI surveillance in both the arms. Primary endpoint is actually an overall survival. This has been built as a non-inferiority. One of the interesting part is obviously allowing for hippocampal avoidance PCI. This is another concept that is actually going through in collaboration with NRG Oncology as well, where they're asking the question, can hippocampal avoidance PCI be better than plain simple PCI? As has been shown in other brain metastases, that actually hippocampal sparing whole brain radiation can lead to very similar outcomes, but decrease in neurocognitive decline in these patients. Next, moving on are some trials that we are championing. This is the Alliance study, basically phase 3 trial of post-surgical single fraction stereotactic radiosurgery compared to fractionated SRS for resected metastatic brain disease. This is a study led by Dr. Paul Brown. This is the schema, but just to inform the people who may not take care of brain patients every day. Now, this has been established in the field when you resect a patient with brain metastases, this has to be followed by some form of radiation, because that leads to benefit and outcomes in this patient population. A lot of times we have done that with a single fraction radiosurgery, but what we also know is because these patients may have big cavities, sometimes fractionated SRS may be better. And as a result, this trial is going to compare this two arms, and the study is actually enrolling quite well. This is another study. Now this is with our collaboration with NRG Oncology, where NRG BN009 is a phase 3 trial of salvage SRS or SRS plus hippocampal avoidant whole brain radiation for first or second distant brain relapse after upfront SRS with brain metastases with a velocity of more than 4 mets a year. Brain mets velocity is a relatively new concept. What it means is because we do a lot of stereotactic radiosurgery, that is focused form of radiation to the brain, you can always have new brain metastases that can come up after initial SRS because you can have a distant failure. This is more of an indication of basically the tumor biology, to be honest, and maybe a surrogate for that. So this is a trial which is basically looking at these patients who may not have that much of a good outcome. So their brain metastases velocity is more than 4 brain mets in the first year at distant relapse. And so this trial is actually randomizing patients to then do SRS plus hippocampal avoidant whole brain radiation. And they're also using memantine. Essentially, what has happened in the last 5 to 10 years is that whole brain radiation has really moved to the back of the line. There has been some interest with that because of the hippocampal avoidance now, but SRS has really become the leading modality to take care of this patient. But then the question is there a poor group of patients rather who have poor outcomes where you may need to do still whole brain radiation but use the hippocampal avoidance strategy? So that trial will champion that, and Dr. Rastavans are a champion for both of these studies. Moving on, there's obviously, Dr. Patel, Dr. Kazrak, and Dr. Yangcha have done a phenomenal effort of DART. And so this is effort being led out of NRG, again, looking at the same combo, ipilimumab and nivolumab, in patients who have unmethylated MGMT glioblastoma. And essentially what it is doing is, this is looking at the same combination of ipilimumab and nivolumab and seeing if this will lead to increased outcomes or improved outcomes in this patient population. And this study is also being championed out of the CNS working group of SWOG. Moving on, this is actually was an effort that we tried to do in DART with the Drs. Patel, Yangcha, and Dr. Kazrak, looking at somatically hypermutated recurrent glioblastoma. And we had put in a concept with CTAP and had some interesting interactions with them. Our concept was actually not allowed because while we were interacting with them, they actually had a concept approved through Alliance, which was a phase 2 study of checkpoint blockade immunotherapy in patients with somatically hypermutated recurrent glioblastoma. Basically, the trial schema is here. This is relatively a smallish study. It's got 2-stage design, 18 patients in stage 1, 14 patients in stage 2. And essentially what they're doing is they're allowing patients with glioblastoma in first or second recurrence who will undergo surgery, and then we'll have tumor tissue which is going to be sent to Foundation 1 to determine if the TMB status of these patients. If they have more than 20 TMB mutations per megabase on Foundation 1 CDX test, they'll be eligible for this trial and will get the combination of nivolumab and ipilimumab. If more than 1 patient have a response first 18 patients, then this will expand to the second stage of the study. So we have expressed our interest in championing this trial out of SWOG because we are very much interested in this concept. This really is an unmet need in our patient population. Moving on to the 2 concepts that are actually have made their way through the working group. I had presented this at the Rare Tumor Committee, and we are going to have a CNS working group meeting this Friday, 10 to 12 Central Time. So those of you who can join it, we welcome you to be there. This first concept is being championed by Dr. Tony Wang. This is a phase 2 trial of atezolizumab and tocilizumab with radiotherapy in patients with newly diagnosed unmethylated MGMT glioblastoma. And this is work again coming out of the Columbia group. There has been some work done at the UPenn group too, where basically they are showing that anti-IL-6 monoclonal antibody improves survival in basically genetically engineered orthotopic GBM. More in models where you can look at this, the patients who get anti-IL-6 antibody actually do better compared to the controls. And essentially, there has been a lot of interest in this modality. In fact, there is a trial being led out of NRG Oncology looking at a combination of IL-6 and anti-PD-1 blockade in recurrent glioblastoma. And this is further work basically showing that anti-IL-6 therapy may be better in decreasing the increasing the CD8 T cell infiltration. And essentially, this is something which is very exciting and decrease of the CD68 cell infiltration. Then this is a clinical cancer research paper, again showing this in vivo now, that the combination of IL-6 can actually, in combination with anti-PD-1 is probably the best way. And this has been the genesis or the reason why the recurrent GBM study is being run out of NRG Oncology. And this is what we want to take to the frontline setting here out of SWOG, looking at the combinatorial effort of IL-6 with anti-PD-1. And Dr. Tony Wang had presented this concept in the spring meeting, which was received quite well. We had presented this idea at the rare tumor committee, and one of the feedback we got was, rather than doing small phase 1 trials, try to go for phase 2 kind of studies. So this is actually our first attempt at it. We are working with the statisticians and try to get CTEP pre-submission call just to gauge interest in this concept. But this will be patients who undergo surgery and then have a diagnosis of glioblastoma, who have unmethylated MGMT. So for those who don't treat this patient population on a daily basis, patients are typically characterized into MGMT, which is basically a repair enzyme. Those patients who have unmethylated MGMT typically do worse with our regular therapies. Here, temozolomide only adds 24 days of benefit in outcome of this patient population. So patients undergo 9 months of chemotherapy with temozolomide for a 24-day benefit. So this is a really highly unmet need in glioblastoma. And so we have now dichotomized trials with MGMT unmethylated and MGMT methylated. And this has been going on for the last 2 to 3 years now. So this concept will be unmethylated MGMT patients, which is around 60% of the patient population that we see. Those patients will get a radiation, which will be standard. Then they'll get a combination of atezo plus toci, which will then be followed by adjuvant therapy of atezo and toci. And the dosages are given here. Basically, it's some of the preliminary stats that we had done and discussed with our group is looking to improve a 1-year overall survival. This is still, again, being put as a single-arm study. We, on the CTEP pre-submission, will see their level of interest, whether they want to support a 2-arms trial. The recurrent GBM study out of NRG is actually also a single-arm study. So this will be parallel effort of that in the upfront setting. And our hope is that we can increase 1-year survival from 50% to 70%. And we'll need 37 patients with an 80% power with an alpha of 0.05. So 37 patients is something we feel very comfortable that we can accrue pretty quickly within 12 to 18 months. Next is a companion trial that we have actually also shared with the rare tumor committee, and which has received support from Dr. Kazrock and the rest of the committee. And this is a concept of TRC-102 and temozolomide in patients with first-line GBM. And essentially, this was work led by Dr. Andy Sloan at the Case Comprehensive Cancer Center when I was there. This drug is actually an academic exercise, was a drug that was invented by Dr. Stan Gerson, who was the Cancer Center Director at Case Comprehensive Cancer Center, and now actually is the Dean of the medical school there. And he basically had this drug called methoxamine or TRC-102, which is basically a base excision repair inhibitor. And essentially, temozolomide, which is an alkylating chemotherapy, and like I expressed, is the standard drug of choice in patients who get glioblastoma. Unlike unmethylated MGMT patients, in MGMT methylated patients, this drug has actually shown to increase survival by 6 months plus. Overall, the drug is used in both the groups because there is still a 2.5-month benefit if you look at them together. But when we give patients temozolomide, the basic mechanisms of affair are twofold. One is the DNA edits which are repaired by the MGMT pathway, and the other are DNA edits which are basically removed by the base excision repair pathway. So this was preclinical work led by Dr. Andy Sloan in orthotopic xenograft models, where he primarily looked at glioma stem cells. And essentially, glioma stem cells have been thought to actually lead to the resistance to traditional chemotherapies and radiation. And what he showed was that the combination of TRC102 with temozolomide actually led to better outcomes. And if you look at it, it makes sense, right? If you're going to have repair mechanisms which are being done by two pathways, if you can have both the pathways being blocked, you'll definitely have a double hit and you'll get a better outcome. And so TRC102 is a basic excision repair inhibitor that binds to the apurine site created through the action of MPG. So this actually was taken to a trial a few years back that I was involved with as a principal investigator when I was at Cleveland Clinic, and we ran this study out of the Adult Brain Tumor Consortium. This was being done in first recurrent glioblastoma, and this was a combination of temozolomide and TRC102. And basically, MRI was done every 8 weeks, and the drug was given until progression. We were set, this was a single-arm study. The combination had a pretty high bar of achieving response rates of 30%, which, to be honest with you, have never been done in glioblastoma. This was a two-stage design study. First stage was 19 patients, and unfortunately, the study did not reach its primary endpoint, and was closed after stage 1. But what we found out was that although there were no responses seen, which is not uncommon in glioblastoma because responses are only around 4 to 5% with therapy. So if you're going to treat 19 patients, there's commonly you will not have responses. Median overall survival on this study was 11 months. Median progression-free survival was 2 months. So this was very much in alignment with what we see. However, we had 2 patients actually who did really well. One had a progression-free survival of 18 months, and the other one had 30 months, almost close to 36 months. Now, when we looked at outcomes of our patients compared to historical controls, what we found out was that the MGMT methylated patients, although the study, like I said, failed to meet its primary endpoint, but there were 5 patients who were MGMT methylated, and there were 14 who were unmethylated. In the methylated patient population, we actually had a median overall survival of 30 months, which appeared very promising compared to the usual 12 months or so we see in recurrent methylated MGMT glioblastoma. So this work was further, then we did a collaboration with TGen, where we actually looked at could there be work being done through DNA genomic testing or RNA transcriptome. And this was work led by Mike Behrens from TGen, and where he actually showed that we could actually look at a gene signature which could actually predict a response in this patient population. So there were 2 patients who did really well, and they had a gene signature where you could actually predict response. And then there was a borderline patient. This patient just basically progressed 6 days before the 180-day benchmark, and but had a borderline gene signature. So what we are doing now is we are building on this premise that there may be a patient population, the MGMT methylated patient population, that may drive benefit, but then we also want to further validate this signature that we have done based on a collaboration with RNA transcriptome. And this gene signature actually in TCGA exists in around 11% of patients with glioblastoma. So it made sense. We had close to 20 patients, 2 patients had the gene signature. So this is a phase 1/2 trial that we want to do with dose escalation, but we want to enroll around 36 patients. Again, we are planning to have a CTEP pre-submission call to get their input. Essentially, these will be 2 sister studies, which will, if patients will be methylated, they will go on TRC102 trial. If they're going to be unmethylated, they will go on the Atizotosi immunotherapy trial. And the essence is to have options for our patients with glioblastoma. With that, I would like to again thank Dr. Kurzrock for the kind opportunity to come and speak with you, and also would like to thank my colleagues, but most importantly, our patients who enroll on trials and help us advance science. Thank you so much for your kind attention.
Well, thank you for that, and also for putting in the time to lead the CNS working group. I'm afraid that I can no longer see the chat, but Dr. Alawali, if you want to see the chat, if there are any questions for you.
I'm just going to look at it. I think there's more of a comment about the PCI of long-term survivors from Dr. Paul Ukinoff, basically stating that they did a study of PCI of long-term survivors with Bruce when he was at NCI. Neurological testing was similar in both groups when the dose was less than 30 grays and the fraction size was less than 3 grays. But they are very supportive of hippocampal sparing. And as you say, there were neurocognitive decline, but the survivors of chemo alone were also impaired. We have video games and things like that for testing function. So I agree with Dr. Kinov. I think it's a very relevant point. We do know that when patient has brain disease, whether it's brain mets or glioblastoma, the very fact that you have disease in the brain will lead to some neurocognitive decline. So there are people who are still proponents of whole brain radiation with hippocampal sparing, and their perspective is that brain disease can be worse than the radiation. And I think this is very exciting avenue where we want to find whether is PCI needed on every patient, or maybe we can find there may be a group of patients where we may need PCI and there are a group of patients where we not need, in this new era where we can do surveillance, and more importantly, where we have really thin cut MRIs now. We actually have slices which can be 1 millimeter thick. So we really can pick up brain mets which are very, very small. This is in contrast to MRIs which were done like 10 years back, where a lot of these trials were done, where the cuts were 5 millimeters or so, and then you would miss small brain mets. So I think in this new age, it would be very relevant to ask that question. I think Maverick trial being led out of SWOG is a very could be a paradigm changing trial, and I would like to congratulate my good friend Dr. Chad Rustovan to lead that effort, and he's a integral part of our CNS working group at SWOG. So I think that will be a great trial for SWOG. But also will ask a very relevant question. And I think hippocampal sparing, whole brain radiation is definitely being investigated not only through this trial but also in the NRG trial, as I said. And maybe that's the way to go, because there was a study done with hippocampal sparing out of Alliance, which basically showed that the degree of neurocognitive decline was close to what has been seen with stereotactic radiosurgery. So I think this is a very interesting paradigm, and I think we need to answer these questions for our patients.
Okay, well, I think we're just about right on time. And I really wanted to thank Dr. Ahluwalia for that talk and heading the group, and also all the other participants. I think we really have some phenomenal things going on: the DART study, the translational aspects, the sarcoma working group, the CNS working group. A lot of opportunities for young investigators there as well. And so I think this is just really a terrific team. And if anybody has any ideas, then or anything else they want to studies to propose, just shoot me a quick email and we'll get you started. And really want to thank everybody for attending today. Have a good rest of the day.
Thank you.
Thank you.
Yeah, I think we've had 88 people attended at the peak of the session. So very gratifying. Okay, everybody, you take care.
Thank you.
Thanks.
Thank you. Bye.